to introduce a really different medical field like the previous lecturers. It is the interventional oncoradiology. I am Benjamin Skribek. I represent the Department of Interventional Oncoradiology. My supervisor is Ákos Deák. And we have a vision that minimally invasive interventional therapies will be readily available solutions for many multiple diseases. We have a mission that we would like to simplify the treatment of patients suffering from various diseases, mainly oncological diseases, tumors. So our aim is to launch novel, human, and effective therapies in Hungary. We have two ongoing projects which in terms of oncoradiology. The first one is investigating the efficacy of minimally invasive interventions versus surgery in the treatment of benign adrenal gland tumors. Adrenal tumors are rare tumors in the oncology, and these tumors have many clinical consequences. For example, the tumor has a hormone-producing capacity. It can cause high blood pressure, hypokalemia. It can cause constipation, diabetes, and other organ failures. The gold standard therapy is laparoscopic adrenalectomy. But LA is not always an applicable therapy, because if the tumor has hormone-producing possibility, the patient condition contraindicates the surgery. For example, the patient has anemia or any cardiopulmonary disease. Sometimes surgery is contraindicated. Laparoscopy has prolonged postoperative hospitalization, has more perioperative blood loss and recovery time. We have second-line therapies like interventional procedures, embolization techniques, thermoablation techniques such as microwave ablation, radiofrequency ablation, or cryoablation. And we have chemical ablation procedures like ethanol ablation. These techniques has reduced interventional duration, decreased blood loss, and less postoperative hospitalization time and faster recovery. So our aim is to compare these interventional procedures to laparoscopy in the case of benign adrenal gland tumors. So we have a clinical question that are these interventional procedures safer and more effective options than surgery in the treatment of benign adrenal gland tumors? So the population is the patients with benign adrenal tumors. Intervention is minimally invasive interventions, in our case radiofrequency ablation and ethanol ablation. The comparator group is laparoscopy, and we have primary and secondary outcomes like complication rate and the biochemical success rate. Secondary outcomes, the operation time, postoperative recovery, perioperative blood loss, and postoperative pain treatment. We hypothesized that these interventional procedures are safer and more effective options than laparoscopy. So we used the following search key, and the search was conducted in 5 databases. And after the selection process, we had only 5 eligible full text to analyze. The first outcome is the complication rate. We can say that there is no statistically significant difference in the two groups. But if we look closer, we can determine that the chance to have a hypertensive crisis during the procedures, it has a 8 times higher chance during a hypertensive crisis during ablation procedures than laparoscopy. In case of resolution of hypertension, the better option in terms of our results, the laparoscopy. So our analysis has strengths. We use articles with similar eligibility criteria. We included not only radiofrequency ablation procedure, we included ethanol ablations also. We used only comparative studies. Limitations, these comparative studies only retrospective studies with low number of patients and focuses only aldosterone producing adenomas. So we can conclude that ablation procedures have higher risk of hypertensive crisis and has lower biochemical effectiveness to the resolution of hypertension. But these procedures have shorter operation time and hospital stay, and it has a decreased perioperative blood loss. So we can conclude that laparoscopy still remains the gold standard therapy, but ablation technique can be an alternative therapy if surgery is contraindicated. But we need more comparative studies, if possible, more RCTs. We submitted our manuscript to the Journal of Helion, it's a Q1 journal, and we are waiting for the response. So our next project is the investigating the efficacy and safety of minimally invasive interventions in the treatment of low intermediate risk prostate tumors. The prostate tumors are the second most commonly diagnosed cancer in men, and usually these tumors are asymptomatic tumors and explored accidentally. The first-line treatments, radical prostatectomy or radiation or chemotherapy. These therapies have complications like erectile dysfunction, total and strand urinary incontinence, etc. So we would like to examine that what is the safety and efficacy of the minimally invasive procedures like thermoablation techniques, high-intensity focused ultrasound, and irreversible electroporation. Our aim is to find the most appropriate interventional procedure for the treatment to low and intermediate risk prostate tumors. The clinical question, which interventional procedure is the safest and more effective option for the treatment of low intermediate risk prostate cancer? The population patients with low intermediate risk prostate tumors, and we would like to compare these interventional procedures to each other. I find the best option. We have two outcomes, complication rate and recurrence rate. So we hypothesize that by comparing these options, we can find the best solution. We use the following search key, and after the selection process, we had 51 articles to analyze. We have only single-arm articles, and we have only 2 comparative articles, and unfortunately, we had to exclude the microwave ablation, RFA ablation, and embolization techniques because the lack of enough articles. So we had many forest plots, and I would like to summarize our findings that we made a subgroup analysis in the groups, and we can determine that 11 months follow-up, the best therapeutic option is the whole gland HIFU. We used pool the data when we do not consider the follow-up, and we can say that the partial or whole gland cryoablation is equal than high-intensity focused ultrasound. The complication rates is really similar between cryoablation and high-intensity focused ultrasound techniques. Irreversible electroporation has disadvantages in this outcome. So we are writing our manuscript, and this is our summary of my 2 ongoing projects. And I would like to thank you with Benjamin Franklin words. Tell me and I forget, teach me and I remember, involve me and I learn. Thank you so much.
Congratulations for the nice presentation. And I would like to ask from you, after the ablation technique,
yes.
Does tumor disappear totally?
No. After the procedure, we use freezing or heating effect to treat the tumor. So the volume of the tumor is decreasing, but we call it remnant tumor, which stays after the treatment, and it's not a functional tumor. It's necrotic tissue, mainly it's a fat tissue. So it has, we don't call tumor anymore, but not disappear.
Thank you very much.
Welcome.
Congratulations to the presentation. I would like to ask that regarding the first project, yes. How could you avoid the hypertensive crises during the ablation process?
Yes, it's a really good question, because the main complication during ablation is the hypertensive crisis. First, we should know that how cause hypertensive crisis. We use freezing during cryoablation and using heat when we use radiofrequency or microwave ablation. And we can injure the cells, and we cause a catecholamine surge during the ablation. So we should blocking the alpha receptor. So we use preoperative alpha blockers to avoid hypertensive crisis.
I found it interesting that you took as your endpoints for both studies two endpoints, two co-primary endpoints, right? Safety and efficacy in both. Yes. I'm not really sure. I mean, you could do it, and it's probably smart to do it. But let's come to the second study. I didn't understand what your efficacy endpoint was. Because what was your efficacy? Because I think it was the same question we heard. Is it a complete treatment? How did you ensure it? Was it a PSA drop? Was it re-biopsies, no vital tumor, or need for secondary treatments to make up for disease progression?
Yes, the recurrence rate. After the procedure, there is a biopsy and imaging examination. Depends on the follow-up time. There are regulations, mainly 12 months and 6 months. So we made biopsy and imaging. So if we can detect active tumor in these and histological positive tumors, so it's a negative endpoint for us.
Because I think you would need to have all those studies at the same time point.
Yes.
Looked lesion-based, or what you treated, and biopsy the lesion. Because if you do, for example, focal, you might have a non-lesion-based recurrence, right? It could be in a contralateral area or something, and it needs to be pathology. I think you probably have done it like this, but I think I would love to see not only efficacy, I would like to say my endpoint is cancer-free on a biopsy done at that time point.
Yes.
Or within that time frame. Or you may say, I have a composite endpoint. Yes. Drop over 70%, sustained at 1 year, plus or biopsy, no cancer, or something like that.
The lack of time, I didn't put the data and the results because we analyzed the recurrence rate in two separate ways. That there is in-field recurrence or outfield recurrence. Yeah. I put into my slide a pooled data. So the overall recurrence rate include the in-field and outfield recurrences also. We have data that these the recurrences mainly are outfield recurrences. Do I answer the question?
Yeah. Mm-hmm. Then the other question I had is, what was your inclusion criteria in this study? The other one is very simple. It's benign lesions. You have the tumor lesions of the adrenal, the malignant lesions, and you have everything else is benign to a certain degree. You have it on MRI, well selected, you have very good criteria. But how did you said the low intermediate risk? This was the low intermediate risk, so it's ASUP group 2 or Gleason score 3+4. Was that standardized? Because how can it be?
Everything was standardized. Every patient has a Gleason score under or equal 7.
Yeah.
The PSA values was also standardized.
Okay.
So the included studies, every study used standardized inclusion and exclusion criteria. So this patient has, every patient has Gleason score under or equal 7.
Because I think the question is, 7 is 4+3, ASUP 3,
yeah,
or ASUP 2, totally different diseases, right?
Yes.
And then the challenge not only with your study, but I guess with all the studies, is one, the technical challenges, I will come to it, but also time challenges and detection challenges. For example, some have undergone a fusion biopsy plus systematic biopsies to rule in or rule out cancer. Other ones, only fusion biopsies. Some have gone systematic biopsies, 6 cores, some 14 cores. So you're talking about a very heterogeneous group of patients you're looking at over time, as you know, with these techniques, because it's very difficult. So your inclusion criteria may have, in those who didn't have whole gland treatment, be one of the reasons of your recurrence rate. Because undetected or not MRI detected, right?
Right.
And there was something that you said is prostate cancer accidentally found. Prostate cancer is never found accidentally unless you do a TERP for prostate cancer. It's totally different from renal cell carcinoma and adrenal cancer, most, the benign ones. Benign ones, sometimes you find them and then while he has, to a certain degree, it could be accidental. But these ones are all biopsied because of an elevated PSA.
Yes.
So it's not actually, it's very different from other, renal cell carcinoma nowadays is small renal masses, you find it. And that also reflects where you are in the disease, right?
Right.
Because it's an early detection, the other one is really even before early detection because it's totally asymptomatic and no signs even. Any other questions? Sorry. But both very important questions, I think.
Yes, thank you.
So in the first project, you included 5 studies, right?
Yes.
Were these all RCTs?
No, all of them retrospective cohort studies.
Yeah, because in the introduction you mentioned an important thing, in the very introduction, even before, that this laparoscopic method is not always applicable.
Yes.
And that means to me that probably in these retrospective studies, the 2 arms, the 2 cohorts will be different because many people will be treated with the new methods because they are not applicable for LA.
Yes.
How could you address this issue?
It's really hard because the included articles do not tell us the conditions of the patients, the comorbidities or conditions. We know that the included patients who had ablation, they or refuse surgery or wasn't applicable for surgery because extreme obesity or has cardiopulmonary disease. But the studies don't give us exact data about the patient conditions. So this is the question for us, that these conditions can cause that in case of ablation, there is a more higher chance to have a hypertensive crisis. But we cannot examine, unfortunately, this. So this causes the heterogeneity.
Yes, but I think it's a very strong limitation what you need to very, very emphasize.
Yes.
And then, okay, and in the second project, you made this summary using the table where I a little bit missed the confidence intervals. Because you provided all the point estimates, which are not easy to assess without the confidence intervals. So how can I tell here which were the significant ones, which are also important for you?
And the important one is the blue results.
From a clinical aspect, right?
And statistical aspect also.
Statistical, so they are the significant
because
ones.
the blue effects statistically significant results and clinically relevant effects inside the subgroup analysis.
And you mentioned clinically relevant. What would you consider clinically relevant?
That if I had the option to choose which procedure I would like to treat the patients, I would like to choose whole gland ablation because it has the lowest recurrence rate and is statistically significant inside the HIFU group.
Okay. Thank you for yes, please.
Just one short.
I'm listening.
If I look the overall results, when I compare the groups, the three groups, it's only clinically relevance. It has only clinically relevance effect because we cannot compare them in comparative studies because it's ethically it's really hard to compare them. This is the cause we don't have any comparative studies.
Thank you.
Thank you so much.
Okay, so in your meta-analysis, you made a comparison between these three minimal invasive surgical intervention and
sorry, it's radiological
intervention. Okay.
Yes.
How can you choose? How can you, or what is your recommendation to apply one or the other intervention? It is based on the size of the prostate, or based on the PSA level, or you will apply the focal or the extended or total whole gland.
It's a really hard question because in many places I would recommend that procedure is available. Because in many clinics only have cryoablation device. Many clinics only have HIFU device. So it's really hard. But if we have every device, I would recommend the cryoablation and HIFU procedures.
Because the lower complication rate?
These procedures has lower complications. And in the literature, they says these procedures have lower recurrence rate in not particularly prostate cancer, in any other cancer treatments.
And the recurrence is detected by the increase in PSA level or the increase in volume in case of a focal intervention?
The recurrence level is detected by imaging and the necessary biopsy after 12 and later. But PSA levels also, there are many cases when PSA levels growing after the procedure, and they made repeat biopsy and it's proved recurrences. So PSA level can show us that there is a recurrence, but in our study, in the studies included, the PSA levels were not well documented, so we do not put into the analysis.
If I may say, just to answer that, the thing you set out to do in a second study is really difficult, because you have a moving target and you have a moving inclusion criteria. It's uncontrolled. I know we have to do it, but it's totally uncontrolled. And for example, cryoablation works well because you're doing transperineally for certain locations of tumor. HIFU works well transrectally, but apical tumors may not work because it's so the inclusion-exclusion criteria will be according to study and patient and technique so different. It's so difficult to compare the endpoints of complications, the selection, and so on. Is really, but you can assume in the best case scenario of experts that use it, and that's how you have to write it, that those experts who've used it, that's the results we have.
Yeah.
right?
Right.
But it doesn't mean the techniques is good, but it's, you know, it's also a lot of expertise, which with every indication.
And as concerns the medical treatment, would you recommend to apply the alpha reductase inhibitors in case of prostate hypertrophy or in case of prostate cancer as well?
I would recommend that yes, I would. I don't know the exact mechanism, but there are many studies say that they use these medicines in the treatment next to these techniques. But we only analyzed articles which focuses only one treatment, not mixed treatment. So we are not prepared an exact answer to this question, but many articles try to say an answer for this question. I don't know the exact answer, but...
Okay, but in case of a prostate hypertrophy,
yes,
the medication of alpha reductase inhibitors could prevent effectively the cancer, the transformation to cancer, or not? What is your opinion?
I don't know, unfortunately, the answer for this question. I don't know.
What's your opinion?
It is not the subject of this, but I would say it's a very mixed opinion. So 5-alpha reductase inhibitors, which are two of them, finasteride and dutasteride, which are receptor 1 and receptor 2/1, that's dutasteride and receptor 1, they decrease the cancer risk. But there was in the analysis an increased risk of high-grade cancers, which eventually showed up to be due to a smaller size of the prostate. In those studies, these were prospectively randomized trials, incredibly well done, with PSA by PSA changes, biopsy, or at end of study, which you couldn't do now anymore, right? And they found that it decreases by 20%, 25% the cancer risk, but increases by a small percentage the risk of high-grade cancer, which at the end turned out to be because you're shrinking the prostate, and when you do the end of the study biopsy, you probably are hitting the cancer more likely. So many of these studies, you're right, use a drug because why? Because most of these patients that have low intermediate risk prostate cancer have biologically insignificant cancer, and they have mostly BPH. And you're treating the BPH and PSA because they drop the PSA by 50% over 9 months. So it's to mask the PSA changes, actually. It's a trick, actually, to make your data look better and not to have triggers for rebiopsy. So it's very complex. Although things change because some of these patients didn't get always rebiopsies because of study indications, right?
Yeah. In an interventional aspect, there are no articles in case of prostate cancer, but in hepatocellular cancer and renal cancer, there are studies pre-embolization before ablation. And it has a similar effect, that is reduce the volume of the tumor, and we can treat more easily with ablation. And it has better effectiveness after the treatment. But in case of prostate cancer, we don't have article, but it's only an interventional aspect.